Hello everyone, welcome back to our NABH training series. Today we are going to discuss one of the most important standards in NABH, PSQ.1, which is about implementing a structured patient safety program. Now understand this very clearly. Patient safety is not just a department, it is a culture of the organization. And NABH assessors don't just check documents, they check whether this system is actually working in your hospital or not. What is patient safety program? Let me simplify this for you. A patient safety program means a systematic approach to identify risks, prevent harm, and continuously improve patient care. It includes policies, committees, incident reporting, risk assessments, continuous monitoring. So if you think this is just a file, you will definitely get an NC. Safety committee, very important. Now coming to the first core requirement, you must have a multidisciplinary safety committee. What does multidisciplinary mean? It means you cannot run this committee with only doctors or only nursing staff. You must include administration, doctors, nurses, facility team, safety officer, support departments. Because safety is everywhere, not just clinical. Meeting requirement. Now a very common mistake hospitals make, they form a committee, but meetings don't happen regularly. NABH clearly expects monthly meetings. And not just meetings, proper minutes of meeting with, discussion points, action taken, responsibility assigned, role of safety committee. This committee is not for formality. They are responsible for developing safety policies, monitoring incidents, reviewing risks, ensuring patient protection. In short, they are the brain of your patient safety system. Proactive risk assessment, very critical concept. Now let me explain one of the most important expectations of NABH, proactive risk assessment. Most hospitals work in a reactive way, something happens, then action is taken. But NABH wants, identify risk before harm occurs. You can use tools like HIRA, FMEA, HVA. Let me give you a simple example. Suppose in ICU, medication errors are possible. Instead of waiting for an error, you analyze where error can happen, why it can happen, how to prevent it. This is proactive safety. Minimum requirement. At least one risk analysis is mandatory. But practically, if you do only one, you are just doing compliance. A good hospital will do multiple. Patient safety manual. Now coming to documentation. Your hospital must have a patient safety manual. This is not a random document. It should clearly define safety policies, risk management system, incident reporting, roles and responsibilities, and very important, whatever is written must be implemented on ground. Otherwise assessor will say, this is only documentation, not practice. Incident coverage. Now let's talk about incidents. Your program must cover all types of incidents, near miss, no harm, adverse event, sentinel event. And here is where many hospitals fail. They don't define these terms clearly. Let me explain simply. Near miss, error happened but caught in time. No harm, error reached patient but no injury. Sentinel event, serious harm or death. These definitions must be documented, known to staff, used in reporting system. Patient safety officer. Now coming to a very important role, patient safety officer. This person is the driver of your safety program, who can be PSO, doctor, senior nurse, quality professional, but must have knowledge of safety and risk management. Responsibilities. They will monitor incidents, coordinate safety activities, report to top management, ensure implementation. And one more important thing, develop safety champions in each department. Because one person cannot manage entire hospital safety. Proactive improvement. NABH does not want analysis only, they want improvement. So every risk assessment must lead to action, implementation, monitoring. Annual review. Now let's talk about review. At least once a year, your entire patient safety program must be reviewed. What should be reviewed? Incident trends, risk assessments, safety indicators, facility inspection findings, and everything must be documented in MOM. Important point. If no improvement is found, even that must be documented. Otherwise assessor will say, review is not effective. National or international goals. Finally, your hospital must align with National Patient Safety Framework, WHO Patient Safety Solutions, International Patient Safety Goals. This ensures your hospital meets global standards. Common NCS or their closure. Now this is the most important part, because this is what actually happens during assessment. NC1, Safety Committee not active. Problem. No monthly meetings, poor documentation. Closure. Conduct regular meetings, maintain MOM with action taken report. NC2. No patient safety manual. Problem. No structured documentation. Closure. Develop manual, train staff, ensure implementation. NC3. No risk assessment. Problem. HIRA, FMEA not done. Closure. Perform risk analysis, document scoring, implement action plan. NC4. PSO not defined. Problem. No designated safety officer. Closure. Issue appointment letter, define responsibilities, show reporting system. NC5. Incident definitions missing. Closure. Define all categories, train staff, use in reporting system. NC6. No evidence of improvement. Closure. Show before and after data, link action to outcome. NC7. Annual review missing. Closure. Conduct review, document MOM, include all parameters. NC8. IPSG not implemented. Closure. Implement policies, conduct audits, provide training. Final summary. Always remember, NABH is not about documents. It is about systems. And systems are proven by implementation, monitoring, improvement. If you follow this approach, you will not just pass NABH, you will build a safe hospital. In the next video of this NABH training series, we will discuss PSQ.1 Quality Improvement Program. If you found this session useful, like the video, share with your colleagues, subscribe for more NABH training sessions. This is MediQuality Partners, your trusted NABH guide. Thank you for watching.